welcome to our webinar with Dr. Ellen Gendler, a board-certified leading dermatologist, and we're going to talk about all things menopause and topical estrogen and answer all of the questions that we get all the time. So I'm so excited that you are here, Dr. Gendler. And before we get started in the webinar, we're going to have a really in-depth conversation. So you can drop questions in the Q&A box, but we're going to probably answer a ton of what's already on your mind. But at the end, we'll save some time and scroll through those. And just be aware, we do have a promotion. It's skincare at checkout for $20 off. So without further ado, I'll just quickly introduce myself, Dr. Corinne Menn. I'm a medical advisor and a prescribing physician at Alloy, and also board certified OB/GYN menopause specialist, and also long-term breast cancer survivor, and was part of bringing M4, to Alloy and help developing it. And just really honored. I've learned so much about this during this whole journey with from Dr. Gendler, I should say. So I'll let you introduce yourself. So thank you for being here.
Okay. Hi, Corinne. I'm Ellen Gendler. I'm a board-certified dermatologist in New York City. I teach at NYU Langone Medical Center for many, many, many years. And how did I even come to be on this webinar? It's interesting because probably 25 years ago, I had a patient, an elderly woman, maybe she was around 82, and she looked absolutely incredible. And I said to her, what's your secret? And she told me that she had been using her vaginal estrogen cream for God knows how long. And it was really impressive to me. And at the time, I just had this idea, I was like 40, and I thought, something, I'm going to try using that on myself. And how could I possibly go wrong? And I started using it really just around my eyes, and I really liked it. And it seemed as though my eyes were not aging as fast as the rest of me. And I started prescribing it to patients. And I've been doing so for the last 25 years. Sometimes I get pushback from dermatologists prescribing topical estrogen, vaginal estrogen, but it didn't matter to me. And I think it's worked incredibly well. And that's how I got into this, sort of became known as a dermatologist who did that.
That's amazing. Yeah. And I think this is how, this is like the art of medicine, right? Like listening to patients, like using like common sense, because as a physician and a dermatologist, you understand the impacts of menopause on women's skin. So from your perspective, can you just tell the audience, let's like give them, kind of basic physiology, what's happening, from perimenopause into menopause in terms of skin health?
Well, I assume that all of you are basically in that point of your life and you're starting to notice these things. And honestly, from perimenopause to menopause, there's a pretty big change. So we know that when estrogen declines in this period of time, a lot of things happen. Your skin becomes thinner, your skin becomes drier, you make less oil. Your collagen diminishes, your elastin diminishes, the skin hydration is worse. So many things happen. And so we work to figure out how topical estrogen can help these parameters. And this is not a new concept, believe me, not new at all.
Yeah. So in terms of it not being a new concept, and just to the point of the physiology, the Menopause Society position statement has an excellent overview of the physiology of what's happening, and kind of just backing up everything that you've just like laid out. But from an interesting historical perspective, I think this is a really fun story that a lot of people don't know about how topical estrogens kind of came to be in terms of the aesthetic, cosmetic world. So can you tell that story?
Well, topical estrogen has been used since the 1920s when Max Factor released their first hormone cream. I forgot what the name of it was, but women were using it all the time. And then, of course, their biggest competitor was Helena Rubinstein, and they launched theirs. And this just kept going. Companies were making these ads about how beautiful you look and how your partner will just think you're ravishing. I mean, really horrible sexist ads. But the bottom line was that it was clear that estrogen was making these women's skin look really good. And this went on till I think it's around the 1940s when the FDA started to come down on more or less drug claims. And they didn't say that estrogen was dangerous, but they said they needed studies. And this kept going until I believe somewhere in the 70s, when estrogen just left the market. You never saw estrogen in creams again. And then, of course, the WHI study just put the kibosh on everything, and estrogen was done. It was done. Topical estrogen done. At
And do
least
you know at all what percentage or what they were using back then in those
I have,
cosmetics?
I have
Yeah.
no idea. I don't know if
Yeah.
anybody knows that.
And I
And
mean, like some
time.
of it was good though that the cosmetic industry was regulated, right? That like if you're putting
Yes,
things in
totally.
to regulate the drugs, right? And then you allude to the WHI, which we talked about a lot on here, and we learned a lot of wonderful things from the WHI. We can't throw the baby out with the bathwater, so to speak, but there in 2002 when it was released, the messaging that went out, the media mismessaging, I would say, caused a lot of fear. And I really think like interest and appetite to put research dollars into anything to do with estrogen was just like gone. And
Right.
so we basically have a generation, decades where this has not been talked about. So it seems like it's new, but to your point, it's actually not new and you've clinically used it for a long time, right?
Right.
And so can you talk briefly about what the research that is there, the research studies that are there on topical estrogens, and maybe kind of like link it to what we do know about the FDA approved topical vaginal estrogen, which we have decades of safety data on it. And it's really okay, in my opinion, to draw a lot of conclusions on that data because we're just talking about skin, right?
Totally. And well, I have so much to say. I could fill this whole webinar with that one
Mhm.
question. But let me just say that as physicians, we use medications off-label all the time, so many ways. So the fact that there exists an FDA-approved vaginal estrogen, there's no reason why you can't experiment and use it on other parts of the body, but you have to do that intelligently. The studies on topical estrogen are not new. It's not that in the last 2 years, since companies like Alloy were created, or however, whatever the number of years is, that this suddenly happened. In the 1990s, they were studying topical estrogen. There are lots and lots and lots of studies. Now, did these studies go on for 20 years? No, they did not. But there are some really good studies. Some of them are double-blinded. Some of them included skin biopsies, and some of them were merely observational studies. But there was a reason for them because there was interest, okay? Even in the 1990s. And in the early 2000s, ditto. I could show you dozens and dozens of studies, and some people would critique some of these studies, but they are good studies. Maybe some of them aren't the most fantastic studies published in the New England Journal of Medicine, but they're excellent studies, many of which are random, they're just vehicle controlled, double-blinded studies, and they're very worth looking at.
And so those are the studies that you're referencing for facial topical estrogen. But
Correct.
you and I also could quote the thousands of studies and data points that we have, enough so that vaginal estrogen is FDA approved, has been FDA approved for decades, and now in the UK is over the counter. Like, let's make that point, right? So, what do we know about how vaginal estrogen works and how effective and safe it is? Like, what are the basic bullet points there?
Well, we know that it's safe. We know that it helps, it helps in sexual issues. It helps in the genitourinary syndrome of menopause. There's so many positive attributes of estrogen vaginally. And the skin of the vaginal walls is very thin. So it made sense to me way back in the day to try using vaginal estrogen on thin skin on the face and maybe on the tops of the hands, the areas where people complain the earliest about thinning. So the area under the eyes, although it has an epidermis, which the vaginal skin doesn't, it still is the most comparable in terms of thickness. And there's so many interesting points about the vaginal estrogen studies. Number one, there was very insignificant systemic absorption from vaginal estrogen. But, and you, Corinne, can explain this to me, at some point, and I don't remember how many years ago, the recommended dosage, say, in Vagifem went from being 25 to 10. And I'm not sure whether that was because there was systemic absorption. You can speak to that. But what was really interesting to me is that when they tested the systemic levels, which were low or almost imperceptible, they were higher on the first day of use of vaginal estrogen than they were at day 14. So what that tells us is that the systemic absorption, if there even is any, is less as the skin or the epithelium thickens. And that's really important to know.
It's super important. I'm so glad you brought that up because we hear that discussion a lot about, any kind of concerns about even a slight amount of systemic absorption in, say, breast cancer survivors who are taking aromatase inhibitors or adjuvant endocrine therapy to keep their estrogen levels really low. We can and we do use vaginal estrogen for those women. And we have looked at what happens with serum levels. And to your point, particularly when women have very severe vaginal atrophy, you'll see a little tick up, not above menopausal levels, but a little tiny tick up in the first 2 weeks, and then it comes right back down to baseline as very rapidly that skin thickens and becomes healthier, which then makes it not as susceptible to getting like systemic exposure. And in terms of the dosing, yes, the 25 milligrams was a higher dose, and you use a higher dose in the top of the vaginal canal, you're going to have a little bit more chance of absorption. So then the studies just showed we can use lower amounts and still get the efficacy. So hence we can translate a lot of that knowledge to using very low dose. Can you just talk briefly about estradiol versus estriol?
Well, estradiol is more potent than estriol. So when you're using a topical estriol, while the results are very comparable, it's still a lower strength. So,
Yeah.
and using topical estriol does not raise the systemic levels of estradiol.
Yeah, and I think this is important, and we'll talk a little bit more about the M4 study. So M4's Alloy's version of topical estriol, and in our M4 study, we looked at estradiol as well as estriol levels, just to really provide assurance at baseline, midway through, and at 12 weeks. And there was no increase in either estradiol or estriol. And biologically, estriol does not get converted back to estradiol. Right. So that's important.
Corinne, why don't you just explain the difference between them? When do we have higher levels of estriol? When do we have estradiol? Blah, blah, blah.
Yeah. So estradiol is kind of the main estrogen that we think of for women's reproductive function. It's what makes your breasts grow and your uterine lining to thicken up in preparation for a pregnancy. It's, what, impacts all of the receptors in your body for you to grow into, as a woman and, support everything. Now, estriol is the primary hormone of pregnancy, and the levels of estriol are in the thousands and thousands when you're pregnant, right? And so your body is flooded with high levels of estriol during pregnancy. And what's interesting is estriol, the physiology of it is very weak stimulant on breast tissue and uterine lining tissue. It's really a much less potent and weaker form of estrogen, right? And so, like you referenced, the studies in the past on topical facial estrogens, some of them used estriol, some of them used estradiol. And when we were formulating the M4, we just went with the estradiol because this is a compounded product, right? So we were trying to lean on the side of safety, as the top kind of priority. And while estradiol would be quite safe too, and you've got lots of experience using it topically from a vaginal form, we chose to go with estriol. So I think they're both valid options.
Estriol is what they use in Europe. They don't even use estradiol, right?
No, yeah. The standard of care for vaginal estrogen in Europe is estriol, and that's what's actually approved for over-the-counter use in vaginal stuff. So let's get to the face, because that's what, we do a lot of talk about vaginas at Alloy, but let's talk about the face today. So actually, and this is a good setup for it. You spoke at the Menopause Society annual meeting in 2023. And in Philadelphia, I think, right? And your talk was amazing. You could hear a pin drop. And when you talked about the workhorses of women's skin health and midlife, like what, and so I'm going to ask you those workhorses, but just for, the audience, when you did the presentation and you got to the estrogen part and you showed like before and afters and you talked about it, like there was like literal gasps, audience. And everybody was abuzz about it. It was such a great presentation. So tell me about the workhorse, and then maybe tell me some highlights from that amazing talk.
Well, the point of my talk was to talk about skincare in perimenopause and menopause in general, and using topical estrogen as an add-on for the standard skincare that we know is very helpful and has been studied in depth. So how do I use topical estrogen? Do I give it to everyone? I give it to a lot of people, maybe not everyone, and I'm not sure how I decide, but certainly if someone tells me that they have had breast cancer or endometrial cancer, I don't take it on myself to prescribe topical estrogen, though I'm fairly confident that it's very safe in all of them. The endometrial cancer people, I'm a little more hesitant with, but there is very good studies on breast cancer and topical estrogen or vaginal estrogen. So, but I tell them, check what you need to check with your physician, with your oncologist and or your menopause trained gynecologist. I'm shocked at how few gynecologists who aren't menopause people don't even know about this. And when my patients ask them, oh, I'd like to use my topical estrogen for my face, they go, what are you taught? They have no idea, and they can't even relate, which is shocking to me, though I do believe and hope that it's getting better now that there's so much publicity about this. But I give it as part of a skincare routine, and you pick your customer, who's going to listen to this and who is not. So there are so many benefits to it. And it really depends on how it's used. And I'm a very cautious person. So I tend to limit the areas that I tell patients to use it on, especially if they're using their vaginal estrogen. Now, vaginal estrogen was made for the vagina. It wasn't made for the skin. So it's kind of ironic that if you go on social media and you see all these people, these skincare formulators and these influencer idiots that are on there talking about skincare, they know nothing about it. But think about it, these vaginal estrogen creams weren't specifically formulated to be put on facial skin. So it's kind of funny that they seem to be tolerated incredibly well when applied on facial skin, which should tell you that most of the stuff you hear about skincare ingredients is nonsense. All right. Really nonsense. We can't use mineral oil. We can't use this. It really doesn't matter. I think that some of the formulations are heavier than others, and I'm not a fan of using really heavy things in very thin-skinned areas because they can be occlusive and give you whiteheads. And so you want to use something that's elegant if you're going to use it around your eyes, let's say. Um, Also bear in mind that these things are formulated for the vagina, so the vehicle, the base that this estrogen is in, may not be that conducive to being used around the eyes. There are certain chemicals that are volatile that give off little aromas when the air hits them, much like sunscreens. You put sunscreen around your eye and sometimes it burns. Well, there's lots of creams. There are a lot of facial creams. You put them near your eye, it burns. So you just need to know that. And if you're going to use it, let's say on the tops of your hands, well, they're not designed to be incredibly creamy and moisturizing. They're designed to attach to the skin of the vagina and not leach out. So you may still have to use a regular hand cream, but these are things to just take into consideration when you use them.
And so thank you for that. And for getting back to your talk at the Menopause Society, you talked about all right, we always have to give women what is the backbone, what is the framework of really excellent skincare at midlife. So just putting the estrogen aside for a moment, what do you think are the most important things you want women to know who care about their skin now?
For me, I have certain things that I call my non-negotiables. I think that virtually everybody should be using some form of retinoid, preferably tretinoin, which is prescription strength, but there are over-the-counter retinols and retinaldehydes that are also useful, though maybe not quite as useful as tretinoin. I think that using antioxidants is helpful because they help mitigate the effects of the sun. They help brighten the skin and things like that. And the things that have been studied seriously are retinoids like tretinoin, vitamin C, which was studied back in the 90s by Sheldon Pennell at Duke with clear scientific, evidence that it works. And then there's something that I'm passionate about, which is called DNA repair enzymes. And those are a really interesting class of topicals that were originally studied in patients with a disease that's called xeroderma pigmentosum. Some of you may know what that is. It's a genetic disease where these kids can literally not go outside. By the time they're 8 years old, they have 500 skin cancers. And it's really a terrible thing. If they look all freckled, it's terrible. And they've studied these enzymes in those patients, and they've been shown to reduce the incidence of pre-cancers, not melanoma, but non-melanoma skin cancers and pre-cancers by about 30%. So for me, that's something I really think of as a maintenance thing that you start when you're young. There's no irritation, there's nothing. They're in all kinds of formulations, serums, creams, lotions, you name it. And you use that as part of your skincare routine. So for me, and then sunscreen, I'm insane about that. And I've given my own talks on the sunscreens in the United States sunscreens versus European. That's probably not perfect, this is probably not the perfect venue for discussing that, but we can always get into it a little bit. So to me, retinoids, antioxidants, DNA repair, and sunscreen. And then if you need to put a moisturizer on top, sure. I tell patients, it's like, look at Dr. Menn. She's wearing a blouse and then she's got her blazer. You want to just wear a blouse? That's fine. You can't go out without your blouse unless you're, what's her name? Mackenzie, whatever her name is, Jeff Bezos' girlfriend. But otherwise, add a moisturizer. If you still feel dry, sure. But that's not your workhorse.
Yes. Yeah, your workhorse are those tenants, the tretinoin, the
antioxidants like
and
vitamin
the
C,
vitamin
right?
C and sunscreen. And then what you added at your lecture, and you always talk about, is then like we've got really good science that topical estrogens can be a nice
Correct.
add-on integral part of that regimen, right? So getting back to like, so how does tretinoin, we get this question all the time, how does tretinoin work? Let's just like, how does it work? And then how does it work differently or complementary with topical estrogens? What do you think about that?
Tretinoin is a completely different compound. It's vitamin A, okay? And
Yeah.
it works very differently. It works mostly in the epidermis, but also in the dermis. It helps to increase the rate of cell turnover. It helps to increase angiogenesis, which is blood vessel formation. And blood vessels are what feed the skin with everything it needs. So that's really what it does. It has been shown to also thicken collagen, but we use topical tretinoin as a way of counteracting majorly photo damage from the sun. It helps with pigmentation and helps make the skin look smooth, lessens the roughness, and there could be a little adjustment phase when you first start it. As topical estrogen is a completely different process, okay? And very interesting, it doesn't seem to be all that helpful in photo damaged skin. That's important. There have been a few studies that have looked at this and found that in sun protected skin, or in people with mild to moderate sun damage, but severely sun damaged skin, you're probably not going to benefit all that much from topical estrogen. So it works totally differently. It works to help thicken collagen, help rearrange elastin, help increase hydration, help increase even, believe it or not, in like sebum production, help make your skin look smoother. Tretinoin is a completely different process, and that's why you using them together is a great idea.
So, and we often get this question about, kind of on the lines of the tretinoin, because with the topical estrogen, we have like one dose right now that we, are offering. It's, has been studied and we feel good about. But tretinoin does come in different doses, and sometimes patients are like, more is better. I'm like, no, So for a tretinoin naive patient, right, someone who's not really used it before, what is your advice on entering into your regimen?
It depends on the person. So I have some patients who are totally averse to one flake on their skin. If they have a moment of dryness, they're quitting. So if you start tretinoin in any strength, and tretinoin does come in different strengths. The lowest is 0.01, then it goes to 0.025, and then it goes up to 0.05, and then it goes to 0.1. Okay. The studies on photoaging skin have been done for the most part with 0.05. Those are the most studied percentages. But what we have and by the way, let me just say that tretinoin is really an acne medication that was brought on in the 50s by Dr. Kligman, very successful. But back then, there was only one strength, and I believe it was 0.1. And it made people sunburn, and that was a real big problem. But from what my research has told me, there was something in the base that seemed to inactivate one of the sunscreens, or the only sunscreen that was used back then, which was called PABA, which has long since been taken off the market. So patients don't really get sunburn when they're on tretinoin, as long as they are using sunscreen. And that's what you have to do. So I don't take responsibility if people are using it and we tell them to use sunscreen and they don't. It's just a fact of life. The most common reason for stopping tretinoin is poor instructions on the part of the doctor, or my least favorite word, the provider. I hate that.
Yeah, we don't really like that word. I know. So I get lazy and use it sometimes because it's everywhere, but I really don't like it. I prefer clinician, doctor, physician over provider. I'm with you on that.
But start
Yeah.
very slowly. And if you start very slowly, you'll get very little irritation and you
Yes.
build up. I tell patients start every third night. Then when
Yes.
you're not so dry, go to every other. And then eventually you go to every night and you should be able to tolerate it. To your point of less is more, probably true, but there was a one really good study that was done where they used the strongest percentage of tretinoin, and people got red and irritated. And if they persevered for 2 to 3 weeks, all of that went away. So I use the analogy, it's like starting at Barry's boot camp. If
You're sore at first.
you get sore, and then you're not. So it's the same
Yeah.
kind of thing. But generally, I recommend that people start at 0.05. And if they're scared to start prescription because who knows why, then I'll let them use an over the counter and kind of build slowly and get used to it and then get them up to tretinoin.
Yeah. And then in terms of the layering of these, so you've mentioned vitamin C, you've mentioned DNA repair, you mentioned obviously tretinoin, and we've got our estrogen. So if people are using any or all of those things, what is a common sense daytime, nighttime approach?
Here you go. This is pretty easy. Tretinoin is used at night. There are some forms of retinol that aren't photostable, so forget about that. You only use it once a day. That's part of your nighttime routine, okay? And I say layer thin to thick. So put your thinnest product on first, wait a few seconds, let it dry, put the next one and the next one. So usually vitamin C is the first product to go on because most of them are very lightweight serums. There are some forms of vitamin C that come in creams and they're heavier, and then it's up to you. So I usually will have them do a vitamin C and
In the
then
morning, right? This is I'm sorry, daytime, right? Okay.
this is daytime. And some people advocate using vitamin C in the morning and at night. I'm not one of those people. I feel that it's most helpful when it comes to sun exposure. So, and that doesn't mean only at the beach. That means you go outside your house to go to work or to the playground or wherever you're going. That's a good time. So I say I have them use vitamin C first, then I have them use their DNA repair product, which is often a thinner serum too.
Yes.
And then they can put their moisturizer if they want, and then they put their sunscreen on. And if you're going to use topical estrogen, then that could go in place of the moisturizer or before it if you really think you need that. That's how
Yeah.
I.
Yeah, that's how I use it in the morning. And because of you, I'm also using the DNA repair. I've tried the
Good.
two of the brands. I'm experimenting with different brands at your
Good.
recommendation. So anybody who's listening, go. Dr. Gendler has some great videos on that, reels on that on her social media and on your TikTok, I think.
But can I
So
say one other thing also that I think is important here? The difference also is that with tretinoin, you can sometimes actually see yourself the difference. There might be brown spots that go. There could be even some precancers that go, and you can actually see that your face looks clearer. There may be fewer, lentigines, age spots, and you can visualize it. With DNA repair, and really, I believe with estrogen creams as well, it's more of a preventive thing. This is something, it's maintenance, it's going forward. You're not really trying to fix a specific problem, okay? With tretinoin, you really are trying to counteract sun damage. That's what you're trying to do, or acne, obviously. And
yeah,
case in point, you have acne, you use tretinoin, your acne can clear up. There it is.
yeah,
But other things are meant to be used for the long haul. So that if
yes.
you start using topical estrogen at an earlier age when you're just perimenopausal, I hope and I expect that you will look way better 20 years hence than
Yes.
you would have if you didn't use it. And that's what's so important. Really
Yes.
important to me. If you say, well, I used the estrogen for a month and I don't see any difference, the difference is going to be what you see in 10
Over time.
years. If there were a way
Yeah.
people could do it on one part of their face and not the other, that would be nice, but no one's doing that.
Yeah, that's really interesting. And it's honestly basically the same thing that we talk about in terms of systemic hormone therapy. We talk about a timing hypothesis, right? Like when we give, the data and the evidence, not that it's not FDA approved for heart protection or dementia protection, but we do have plenty of data that if we started early in that ideal window, we're going to have all of these benefits that kind of are hard to see until down the road, that you just didn't develop all those things down the road, right? So kind of shoring things up while you're at this vulnerable time and then continuing on for maintenance is this kind of idea, right?
Right.
And this is why a 20-year-old, really, frankly, it's not going to hurt you, but a 20-year-old doesn't really need topical facial estrogen, in my opinion, right? It's for when you're having that time of that initiation, that vulnerable time of perimenopause, which could be up to 10 years prior to your last period. But when you're starting to notice those changes,
Right.
that's a reasonable time to incorporate it into your regimen,
Right.
right?
And if you start when you're 60 years old, you're not, you have to realize you're not going to see dramatic differences. You're not going to suddenly say, oh my God, look at my eyes. They look, it looks like I had surgery. That's not going to happen. But if you
And it's interesting because, and sometimes we have like 75, 80-year-olds come and they want it. And I said, that's fine. You can have it. It may
okay,
help with like maintain some moisture and help, but it can't completely reverse stuff that's happened. But then they say, but why does it reverse stuff in the vagina? I'm like, because your vagina didn't see the sun. Your
that's exactly
vagina
right.
doesn't have photo damage,
And
right?
it
And
doesn't
so,
have an epidermis. Right. Right.
yeah, so
Yeah.
that's kind of the difference, there. Um, Okay, so sometimes people ask about these SERM-like,
Hmm.
which you could explain what that is, SERM-like estrogens, MEP, and I'll let you explain it, but I think that this as an alternative to topical estrogen was really born, frankly, this is just my opinion, out of the
So,
fear of
yes.
estrogen, the fear of the WHO. I even found dermatology articles saying like, because estrogen is so bad and dangerous, we need to find something else. I'm like, no, 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 this is
Right.
crazy. But
But
so
it was a good, there was a good reason
good
because
intention, but not,
well intended because they knew that estrogen, would
they
be
were
harmful to the
fearful.
skin. So what are SERMs? Selective estrogen receptor modulators that aren't actually estrogen. That's what
Yeah.
they are. And they're chemicals that interact with the estrogen receptors in the skin, of which there are, I don't know, billions. I'm making that up, but every tissue you have, practically every organ has estrogen receptors, and they interact with that. But somehow they don't interact in the same hormone pathway, which is really pretty interesting a concept that they seem to activate the receptors, but not through the same pathways, even though they competitively fight for those receptors with estrogen. They don't do it in the same way. So that's interesting. But in all of the studies of topical estrogens, the SERMs are not nearly as effective as estrogen or estradiol or estriol itself. And there are some things called genistein, there's soy
Oh, yes.
flavones. And back in the day, I remember when if you had breast cancer, and I honestly don't know now if this is something that people talk about, they would tell you not to drink soy milk. I don't know if they still do that. I haven't really heard.
No, they don't. And in fact, they say the opposite, that, whole soy foods, so not like soy isolate protein, right? Like just crap. No, but real soy, tempeh, edamame, good quality soy products. They are healthy to bring
Right,
into your diet,
right.
and they're good sources of protein for a lot of women as well, tofu, et cetera. And American Cancer Society makes that very clear on their website. Soy is healthy. It's okay. You can have
But
it. But
back
there
then,
was
they
this,
thought it was, I think, because soy was equal to estrogen, which it's not.
yes,
That's
yes.
what I think.
And we shouldn't fear
Right.
really any of it. When we're talking about estrogen, everything has to be taken into context. And from a science, not fear-based approach. And there was a lot of trickle-down effects there, which that's where I think this MEP comes in. Again, it's not wrong. It's interesting. It's an option, but I think it's an option that is not necessarily as needed because we actually have really good data on what actually does
And
work.
the other thing is that the studies have shown that the SERMs activate the beta estrogen receptors rather than alpha. And we know that the alpha receptors are the ones that are the breast cancer, they're involved
They're
in
more related, yeah.
or related in reproductive cancer. So we don't really worry about that. The problem is that these SERMs don't really do that much. But if you are totally opposed to using topical estrogen, sure, go ahead and try it. The studies are not impressive, but they feel kind of nice, and they're not going to be you're not going to get nearly the results that you do with actual estrogen.
And I want to clarify for anybody listening, just from a topical cream standpoint, some people get a little confused because out there is a whole world of compounded HRT, right? What does that mean? And it's often in cream forms. So patients tell me, oh, but my friend is using an HRT cream and it helps her hot flashes and her night sweats. So how come this facial estrogen cream you're saying is not systemic and it doesn't help hot flashes? And I said, no, 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 you have to understand compounded HRT creams are totally different formulations. These are higher potency, different doses, and these are trying to compete with FDA approved options for hormone therapy, like estrogen patches, sprays, gels, pills that are FDA approved. So at Alloy, for instance, we only prescribe FDA approved forms for hormone therapy. If you hear people using creams that are for hot flashes, they're not referring to topical facial estrogen or vaginal estrogen. So that's one like common question we get. And then the other thing, and I want to hear from you because I'm sure you get this from patients, is people can go onto Amazon and they can type in estrogen cream for your face, estrogen cream for your face. There's no prescription involved. There's no percentage listed. Like, what is up with that? Where are these products coming from? And what is
China? I don't know. I made that up. I don't know where they're coming from, but you shouldn't. All I know is you shouldn't be using them. Okay.
Yeah.
And that brings up a very interesting little concern. And you've probably read about this and you've probably seen this on social media. There were people who brought up the issue of estrogen creams, topical, causing breast cancer. And this is something that I go crazy about. There was one case report. And it was a 93-year-old woman. I read this report 500 times and I chuckle. This woman used a topical estrogen cream that I've never even heard of. I think it was, I don't know if you've ever heard of, like ethinyl estradiol. I don't know, but it was something like one of these compounded things. God knows who gave it to her. She used this cream 3 times a day for 75 years over her whole body. Okay. And I went into a deep dive with this, and there, there've been talk about this, it's caused her to get breast cancer when she was 93. Okay. That is the equivalent of using like 1.5 tubes of a standard estrogen cream a day for 75 years. Okay. So don't use that as a reason not to use topical estrogen.
Yeah. Yeah. It is, to me, these kind of scare tactic stories out there don't really serve women really well. And it made its rounds about a year ago. And these things pop up sometimes. So when you hear fear-based information, based on a case report or something, you have to be an educated consumer. And I know it's really hard for patients out there to there's this whole world of information, but there's ways to kind of screen out things. Ask, is the person have an agenda, or is the person an expert in whatever they're talking about? What's the source data there? But that was kind of, and I think that was one of the cases that you presented at the Menopause Society, saying this is not a reason to fear this, right? So anyways, interesting that you brought that up. But yeah, so be careful about any of these things that are like over-the-counter hormones. I don't care whether it's for your face or for anything part. Yeah. Over the counter, they're not I actually don't know how legally they can even be sold on Amazon because they say that there's drugs in them. So I would just avoid that.
Right.
So
wait, Corinne, let me say one other thing. I've had a lot of patients say, when I say, well, do you have a vaginal estrogen? Because you could, if you have that already, you can just use that. And a lot of people will say to me, well, I have like an estrogen gel. So I don't like using gels around the eyes. They're irritating and they're not meant for use around the eyes. So just know that. And then I'll either give them, a prescription. I'll say, well, maybe see if your gynecologist will switch you to a vaginal cream, or else I'll prescribe something like the M4 cream from Alloy to use.
Yeah, and so anybody who's asking about gels, there's an FDA-approved product. Divigel was the name. It's now you can get it in a generic form, and we prescribe it at Alloy for systemic hormone therapy. They're the little gel packets. You use them once a day, various doses. These are for hot flashes, for night sweats, for prevention of osteoporosis. I would never tell any woman to take that gel, 1, and put it on their face. 1, because the vehicle is not right. 2, this is systemic estrogen. Right. So there are no FDA-approved gels on the market that are for local dose. There's only a vaginal estrogen cream on the market. So it's a spray or a gel. It's not meant for your face. If you're getting it compounded in some form like that, I still wouldn't use a gel on the face. I agree with you there, but it gets confusing out there for these women. So I'm glad you pointed that out. I want to ask about some of these kind of side effects, things that people often ask me about topical estrogen. So the most common
where you're going here. I know where you're going.
Melasma.
Well, let's talk about melasma. This is really interesting too. Do any of you know do all of you know what melasma is? It's pigmentation on the face that's used to be referred to as the mask of pregnancy. And it's a dark pigment that typically appears over the lip, but it can occur anywhere on the face. There's a lot of concern about that. And there definitely are some reports of people using topical estrogen and getting melasma. However, when it's been studied, there haven't been in these control studies, there haven't been reports of melasma. Now, that could be for a variety of reasons. Number one, it could be because people are using the estrogen for years and, for a long time, and then they get melasma, and the studies are 12 weeks, 16 weeks, 20 weeks. Maybe that's a reason. But estrogen doesn't appear, although it does drive the synthesis of melanin. It doesn't do it just by virtue of its hormone action. And people who get melasma in pregnancy tend to get it when they're on the birth control pill too. But women who've gotten melasma when they're menopausal, when they're on HRT, did not get melasma when they were pregnant or on the birth control pill. So it's really interesting. So what do I tell my patients? I say that if you tell me that you're worried about getting melasma, then here's your choice. Don't use it all over your face. I don't think I've ever seen melasma occur under the eyes ever. So I would say just use it on limited areas. And if you want, you can put some on your neck. I don't see melasma there. There are sun damage you can get on your neck, but I never see melasma.
Yeah.
And let's say you don't think you have melasma, but you use it and you feel you're getting it, then just treat the melasma like anybody else would. And then if you want, stop using it on your cheeks. This is not like you have to use it all over your face, your neck, your arm. The
Yes.
areas that you want to treat. And if you have a problem, then you stop. But it's very, very uncommon. And I believe that the people who get melasma after using topical estrogen are probably those who have had it before and they know about it.
Yeah, I agree. So I've been prescribing alloy, the M4, for about 2 years now, and I see patients on a lot of speeds. So I've prescribed a lot of M4, and I've had just a handful of people who said, after using it, I feel like maybe my melasma has been triggered, and I said, okay, that's I
Okay.
believe you. I believe women when they tell me that, and I said, okay, pause it. Let's maybe switch
The
to
melasma.
tretinoin or stick to tretinoin. Talk
Right.
to and generally this is something that's resolved pretty quickly, and this is not a big thing to worry about in general. And to your point,
Well, let me tell you one other thing apropos of a study with melasma. There was one study done, I forgot, maybe it was 2007, I think. And there was a report of melasma of a woman who was using it on her arm. She was using it twice a day, and she was using a gel, a very high strength estradiol and estriol combination on her arm twice a day. And she developed melasma or pigmentation on her arm. This was a bad study for not, it wasn't a study, it was a case report. It was bad for so many reasons. Number one, the woman was from Florida, and we have no idea what her sun exposure was. And for all we know, she put it on twice a day and sat in the sun all day. We don't know. So it's not that. It's something that happened, but you can't draw conclusions from something like that. Much like you couldn't draw the breast cancer conclusion from the 93-year-old using it 3 times a day for 75 years. Similar problem.
so yeah, in general, and then in the M4 study that we did, and yes, it was short, it was 3 months long, but we saw no increase in pigmentation or any signs of that. So that was also a data point and reassuring. So when patients come to me and say, okay, Dr. Menn, I do have a history of this, but I'm still interested in giving it a try, I'm like, oh, let's try it. And you could start in a small area and just see how it goes. That's a reasonable way. The next skin condition that people ask me about, it's something that I deal with myself, and I've actually found it to be helpful, but I would love to hear your comments on this, is rosacea, which I know is really common at midlife. So can you just tell us maybe like what rosacea is and like why it's so common, it seems, at midlife, and what are your thoughts on topical estrogen and rosacea?
Okay. Rosacea is a condition where you develop facial redness, flushing, and sometimes little pimples all over your face, but mostly in the central portion, and happens in men and in women. And it's believed to be because of an overgrowth of a certain kind of mite called the Demodex mite in the skin. And some people are prone to it, seems to be more in fair-skinned people, etc. There's lots of ways we treat rosacea. And one thing that I've noticed in my 35 years of practicing dermatology is that the more creams you apply to rosacea, the worse it is. Rosacea doesn't like to be fed because these mites, they thrive. And honestly, I see no benefit from using estrogen in rosacea. There's no reason why it should work, but if you think that your estrogen cream helps, it could be for several reasons. One being if you're using your estrogen cream instead of many other moisturizers, like let's say you use your estrogen cream and you say, oh, my skin feels so moist, I won't use my other two moisturizers that I pile on. Well, your rosacea might get better because you're using fewer things on it. But I don't consider, honestly, I don't consider estrogen as a
But
treat.
it's not hurting it. That's the question. People are like, I have rosacea. Is it going to hurt it? I says, no, I don't think it's going to hurt it. We know it improves in general, like the skin barrier. So like,
But, rosacea is not necessarily a skin barrier problem. There's a lot of talk about skin barrier now. Every cream they're giving
yeah.
disgusting creams. The estrogen creams we use they're not thick, slugging Vaseline creams. They're elegant cosmetic preparations that you're
Yes.
using, like the M4. And I don't,
You're
that's,
not worried. Yeah.
I'm not worried, but I don't say, oh, you have rosacea, let's use estrogen. I don't.
Yeah, I know. I understand that for
But
sure.
I tell people, don't worry about your rosacea if you're using it.
Perfect. And I've heard some influencer doctors out there who are skin doctors who I suspect don't know a lot about menopause
Sure.
say
Yeah.
that, well, you have to be really careful if you are going to use topical estrogen because it can cause melasma, it can cause increase in blood vessels, it can cause, you have to be really careful if you have a family history of breast cancer,
Don't get me started on this.
and it's like, I'm like, if you're going to give information about anything to do with menopause, you have to have a basic understanding that, we don't even deny systemic hormone therapy to people with a family history of breast cancer. To sit and scare women,
it's terrible.
Things, it's ridiculous.
But I have my theories about that, and most of these dermfluencers, they're 25 years old. Many of them, that's not fair to say most, many of them haven't even practiced, and they earn their living not by seeing patients, but by being on social media and being supported by brands. And I can tell you now, Pfizer, who makes Premarin, is not paying influencers to talk about it. Alloy is not paying influencers to talk about it, so they don't get any money from it, and they know nothing. So suddenly, I talked about at the NAMS meeting, you started getting a lot of publicity, though I've been doing this for 25 years quietly in my own New York City practice. Now they find something controversial that has clickbait, and they're on it.
Yeah,
and
the
rosacea one, I made a video about this, and I got a lot of hate mail, but I don't care. So don't listen to that. It's nonsense.
So, all right, what about people who have had a skin biopsy for basal cell carcinoma, melanoma concerns? Talk about that.
Absolutely zero connection. It's like we're buying a shoe or buying a new car. It has nothing to do with it.
Okay, I'm going to jump to the Q&A because we've got like 10 minutes or so left. When you put the estrogen around your eyes, do you put it on just under the eye or do you also put it on the lid? Okay. I put it on my lid. I do.
No, I don't put any cream on the lid. This is what I tell patients. The only time you ever put something on your eyelid is if it's eye makeup or you have a contact dermatitis and you need to treat it. No eye creams of any sort on the eyelid.
Okay.
Go right under.
Okay, good. Yeah, I put my forehead under here. I'll avoid the lid.
Stop to the eyelid.
Here, and I kind of just like drag whatever I have left down here. Can someone with high blood pressure use topical estrogen? Yes. We can both answer that. Will I experience all these menopause changes in the skin if I'm taking MHT? I can answer that. From the Menopause Society guidelines, we know what happens with the loss of estrogen. And it is suggested that systemic hormone therapy is likely going to help your skin as well. But that's not a reason why we prescribe. We would never prescribe systemic hormone therapy only for skin or say anything about skin in terms of that. But I will say that 50% of women who use systemic hormone therapy from a vaginal sexual standpoint, it doesn't do enough to treat genitourinary syndrome of menopause. They still feel vaginal dryness, atrophy, lack of lubrication. And I'm going to guess that that's probably, you're going to have a benefit.
And the other thing is there have been studies in women who've taken menopausal hormone therapy alone with no topicals. and the skin, and then those who are on menopausal hormone therapy and add topical, and the benefits to the skin were much greater in those using the both of them, systemic and topical.
This is a question that I know we don't have the answer to, but this also leads to what we hope for research. I think, what dose concentration of estrogen cream is the most efficacious for anti-aging? Let's
Who
get the
knows?
NIH to study that, or someone. Anybody out there want to study that? So, it's something we have future hopes for, right, Ellen?
Right.
Can you use estrogen cream on the hands for anti-aging? I think you mentioned it, but this is like a thinner area, right? Can you use retinol on your hands?
Sure.
Yeah. Do you?
Of course. My hands are old. I don't have any spots.
You have nice hands. What is the alternative for retinoids for folks with super sensitive skin? I have rosacea and sensitive skin that does not play well with retinols/retinoids, so don't use them. Right?
Don't use them, or use it over the counter. But I would say you will be able, most people can use them if they use them right. That's all. So you need better instructions.
Now, these are the questions that everyone always wants to ask the dermatologist. So we've got a few minutes left. Do you have any brand recommendations for the DNA
No.
enzymes?
For
No, but
what?
you can go listen.
For DNA repair? Yeah, that's easy because there aren't very many companies that have products that use them. There's one company called Photozyme, another company called Neova. There's another company called Priori. There's a very expensive line named Macreen Actives. Let me think. Skin Better has a product called Alta Defense that has DNA repair enzymes. Those are a bunch of brands.
Here, getting back to, because this is always common, I have brown spots on my skin. Are you saying that topical estrogen would not work for me, or that I need to use tretinoin and then topical estrogen, and will it make melasma worse?
Topical estrogen does not treat brown spots. Does not treat
Very
them.
important.
So it has nothing to do with it. Yes, use tretinoin, use your bleaching agents, all the other things you need to do.
Yeah. How to manage retin-A if I work every day in the sun? Use sunscreen and a hat, right?
And use the right sunscreen. And that's a topic for another webinar on what's a good sunscreen. And certainly American chemical sunscreens are not your answer. Okay, European chemicals are your answer. But that's a whole other topic.
That is. And you have a lot of great content on your Instagram about the different sunscreens. Can people use red blue light when you're using estrogen creams?
I
I
don't
know
know.
you're not a fan. You think that
I'm not a fan of red blue light either, so I guess so. You let me know,
Yeah. This is a common thing I hear people talk about. I had a total hysterectomy in 2023 with my ovaries removed. I'm 62. I gained a lot of weight. I lost 30 pounds, and the weight loss caused loose skin. My neck looks like a turkey neck. Will estrogen tighten the skin?
No.
Too late.
No.
Is it going to improve like skin, help things, whatever in your face? Yes, but we have to be like set realistic expectations. You have lots of loose skin, weight loss, turkey neck.
You're 62 years old. Estrogen is not reversing your turkey neck. Surgery will. And if you have surgery, then use the estrogen to help keep the results going.
What about eczema? People with eczema?
Nothing, it's a nice creamy base. Yeah, it's fine. Yeah.
Yes.
I would use it to treat your eczema, but it's not going to harm it.
Yeah. Can you use it on your upper lip? Sure.
Well, sure, but
I mean, not lip. I think they mean.
No, I know what you meant. But let me just tell you, what you're trying to use it there for is to prevent wrinkles. And this is the most active area of the face, other than the eyes, which blink more than than the mouth moves. You get these lip lines, even if you don't smoke, because you talk, because you eat, because you drink. So putting estrogen cream there is not going to prevent your lip lines. And so I don't recommend it as a preventive for lines. It's just not, that's not what it is. It's for thickening your skin, making your skin look nice, but it's not for actual line prevention.
Oh, Ellen just froze for me.
I did?
Oh, you just froze for a second for me. So what do you go to the dermatology conferences, what do you see in terms of what's the level of interest in this, in terms of, we know there's a lot of interest from women and in the menopause world. What are you seeing in the dermatology world?
It's funny, not a hell of a lot of interest. And
I thought, yeah,
this will sound really terrible, so take it, with a grain of salt. I think that in the skincare arena, the things that many dermatologists look for are things that they can earn some
make money on.
Yeah. And so, they get nothing from, writing a prescription for it, but if they can sell it in their office, and that's why MPEL is I think a lot of derms might sell that in their office, but you don't sell M4 or any of the other estrogen creams in your office. And so I think that has, that makes.
Yeah, no, it's not a terrible thing to say. It's just an honest thing to say. My own dermatologist, who I really love, she she's very much like you, very common sense, and like these are the things that work. And she actually doesn't barely offer or push a lot of fillers and stuff, because she's like, listen, yes, we can use them and there could be a role, but she's like, a lot of the things that are offered are also making a lot of money, right? And so I'd rather people like not think too much and use what works, keep it simple, and use effective science-based things. Not that some of these other things that you pay money for can't be helpful, or you might like them or whatever, but let's.
Well, that you asked the question you asked was, why don't dermatologists talk about it more? And I think derms who are interested in menopause probably do, but there's a limited number of us that are like that. Although now every dermatologist is calling him or herself the menopause dermatologist, which is also funny.
But also, I think why are they also, maybe there's less interest there because there's a trickle down, right? It was only a few years ago that even in the OBGYN world, or even just any popular culture, would you even hear someone even admit that they were menopausal? It was like a shameful thing. No one wanted to talk about it. And so it's going to take time. There's a trickle down. And I didn't get any training about menopause in my residency. I seriously doubt dermatology residents are getting large amounts of instruction on what happens to the skin in menopause. Is zero, right? And so that's why it's going to take time. And I see it as a grassroots thing. Like, women are interested, they ask the questions, it makes the dermatologist curious and hopefully pushes it.
And they'll learn. I agree.
And then do you think that there'll be any interest from the pharmaceutical industry standpoint of doing studies and developing, because they can make money?
I hope so. I mean, I really hope so. I wouldn't be surprised if it's happening as we're on this webinar. They're, who knows what they're up to. They might. Yeah.
So anything else, because we've got like a minute or two left, anything else that you would like to, tell people about? Anything, skincare, topical estrogen, menopause, how to get information online. And anybody listening to this will be recorded on our YouTube channel, which Allie's YouTube channel is like a free masterclass in all things menopause. So if you've got a friend who you think would want to listen to this, it's going to be on there. And you could also follow Dr. Gendler. What's your handle on social media?
Just my name, Ellen Gendler, MD. Yeah.
Yeah. And so follow her, and she's got great information. But yeah, so anything else that you want to
be very suspect when you hear information, when you see information on social media that is out there, and then look for people whom you consider to be experts in whatever their field is. Real experts, not these people that have no credentials whatsoever and are talking about beef tallow and whatever other nonsense. Listen to people who have some gravitas behind them and see what they're saying, and even, write to them. But in this menopause arena, you should be able to trust your menopause specialist gynecologist, and there are some menopause specialist internists who know about it, and a dermatologist who's well-versed in menopausal skincare.
Yes, absolutely. And I'll tell people, just because the big pink elephant in the room is always fear of breast cancer in anything when it comes to menopause. So I'll tell anybody listening out there, I'm a 23-year survivor of breast cancer, and I use topical facial estrogen, and I'm not afraid of it. And my friend and colleague, Dr. Eleanor Teplinsky, a great oncologist who's got a great, very informative evidence-based social media, she talks about that really in general, she's not afraid to use it with those patients. So anybody who's got a complicated medical history, this is why we will ask you to, you'll come, you'll see, you'll get information from a menopause specialist at Alloway who will review your medical history, make sure it's appropriate for you. But to just like kind of put it out there, in general, we're really not afraid. We're talking about low dose, safe, topical options. So you've got choices and options.
Right. Yeah. I wouldn't be surprised, Corinne, if in the future there are other types of estrogen related compounds or estrogen receptor compounds, much like they use in breast cancer, that maybe will start being developed topically as well. I wouldn't be surprised.
Yeah, it'll be interesting to see what happens. Well, this was just such a pleasure. I love learning from you. You're fun, you keep it real, and we're really grateful. that you were here. And anybody listening, remember skincare, $20 off your order. So check it out at Alloy, and you guys all have a great day and a great weekend.